Morning, Mr. Chairperson and ladies and gentlemen. What do these trials say? If I can be blunt and crude, honestly, they say nothing. They just throw the gauntlet at you and say, do what you like. There is enough evidence base in the literature for anything that you want to do. Whether you want to treat them medically or surgically, stenting or endarterectomy, there is base. And the trials have limitations. Some of them have not included the symptomatic patients. The use of embolic protection devices was not mandated in all trials, barring a couple of them. Inexperience of operators has been alluded to by Michel. Look at the French EVA trial. The expert operator was labeled as anyone who has done 12 stentings. And we know at 12 stentings, where do we reach? Most trials were terminated prematurely, and there is no uniformity of conclusions. And that's why you see in last 6 months or so, you have had 5 guidelines, each one of them singing their own tune. Let's look at some of these trials and the statistics. Now, it has already been alluded to that endarterectomy established and validated itself against medical therapy in both asymptomatic and symptomatic carotid stenosis almost 20 years back. But it was also realized that the endarterectomy has fairly significant adverse outcomes associated with it, and that's why stenting came in vogue with all its perceived advantages. And it was also validated in a fair number of large registries as at least being reasonably close to endarterectomy in high-risk patients. But then it was also soon realized that stenting is not the panacea to all problems, and besides the routine complications, the MRI detected cerebral ischemia of nearly 50% in the ICSS study raised a lot of questions. And that's why it was mandated that the embolic protection devices must be used in all patients. Now, let me come to these trials, and I'm going to present only a few of these, maybe 5 major randomized trials. The SAPPHIRE, which looked at both asymptomatic and symptomatic patients, and the rest 4 of them looking at only symptomatic patients. And then we will have a word about the CREST trial, which has already been discussed in details by Professor Henry. Now I look at CAVITES trial, no difference between the 2 procedures. The SAPPHIRE trial shows that the endarterectomy had higher adverse events as compared to stenting, and this was essentially driven by higher myocardial infarction and higher cranial nerve injuries in the endarterectomy group. If we look at to the opposite side, the SPACE study, as well as the French EVA-III study, showed that there were increased stroke and death with stenting, and the non-inferiority of stenting was not proven. Granted, these trials did not mandate the use of embolic protection devices, so they are not truly contemporary trials. The ICSS study, again the same finding, much higher adverse events driven by higher stroke rates in stenting as compared to endarterectomy. And in its MRI sub-study, they found new ischemic lesions in nearly 50% of these patients as compared to around 14% in endarterectomy. And majority of them were asymptomatic, but nevertheless, they were ischemic lesions on the MRI scan. Now, just as these trials came in the last 3 years, we've also had a surfeit of meta-analysis, probably outdated because it looked at trials in the yesteryears, but 30 days adverse outcomes higher was stenting. A little more contemporary, Bangalore et al., Murad et al., published last year, against higher mortality and stroke by almost 60% higher in stenting. And these adverse events were more often seen in the elderly patients. Look at that, 12% in stenting versus 6% in endarterectomy, a very high statistical value. On a multivariate analysis, Giles et al. Looking at a very huge database of CMS database, almost 500,000 endarterectomies and more than 50,000 stenting, found carotid artery stenting as an independent predictor on multivariate analysis for adverse outcomes, as was also the symptomatic status. If you had symptomatic patient, the adverse outcomes were much higher than in an adverse events in an asymptomatic patient. And if you look at the Society of Vascular Surgery registry database, which was published just last month, if the patient was more than 65 years, irrespective whether he was asymptomatic or symptomatic, stenting had more adverse outcomes. But if the patient was younger, then the asymptomatic patients had statistically significantly adverse outcomes as compared to endarterectomy. Now, as if the confusion was not enough, again, a very recent presentation of 2011 and another one of this very year, where they found there was no difference between the stenting and the angioplasty, and the endarterectomy. 5-year survival rates were exactly the same. Whether they were symptomatic or asymptomatic, no difference. Whether they were young or old, no difference. So that's absolutely a diametrically opposite view to what the registries have been showing. And then came in 2010 an important landmark study called the CREST study. Important because it included symptomatic as well as asymptomatic patients. Important because as against other trials which were done in high surgical risk patients, this was normal risk patients. Here the distal protection devices used was mandated, and there was a threshold for operator experience. And what was found? More strokes with stenting, more myocardial infarction with endarterectomy, and because of these countervailing adverse events, overall 4 years and peri-procedural death CVMI exactly the same. They also found young patient did better with stenting and elderly fewer event with endarterectomy. And based on this trial, the FDA expanded its indication for stenting, which was earlier high-risk cases for stenting. They now included standard risk patients also for stenting, but with a caveat that it is a prerequisite that an operator should be able to achieve a composite endpoint of less than 6% CVMI in death for symptomatic and less than 3% for asymptomatic carotid stenosis. Now, based on these, we have last year the guidelines with all this database, conflicting database, the guidelines were released. The American guidelines for symptomatic patients, both endarterectomy and angioplasty or stenting are a class 1 indication, but with moderate stenosis, the benefits are modest. With tight stenosis, more benefits, and the level of evidence base going for CA is level of evidence A, that for stenting B. But if the patient is asymptomatic, the cutoff figure of stenosis was taken as 70% and above, and endarterectomy was a class 2 indication, and stenting a class 2B indication, with these forming a very standard contraindication for any intervention in carotid stenosis. Now, as against the American guidelines, the Society of Vascular Surgery and the Australasian guidelines said that stenting should be done only for symptomatic patients. They ruled out asymptomatic patients totally. And even the symptomatic patients only if they had certain contraindication or high risk for carotid endarterectomy, things like scarred necks because of previous neck dissection or radiotherapy, or high-risk comorbidities for endarterectomy, or if the patient was anatomically not suitable for endarterectomy. Now, the European guidelines are closer to the SVS and the Australasian guidelines, and they give a very weak class 2B indication for stenting only for symptomatic high-risk patients for carotid stenosis. And the British guidelines say, to quote, the evidence on efficiency of stenting, and they give guidelines only for asymptomatic, is inadequate. should only be used with special arrangements for clinical governance, consent, and audit or research. That is only under controlled situations we should use these. So you can see the 5 guidelines. They have total diversity and recommendations, and they have been assessed in a very important paper. Last evening I got hold of this journal, Paraskevas et al., who has assessed them very elegantly, and they find that the guidelines are ambiguous. And look at the language used in the guidelines. If I can quote, for recommendation for stenting in asymptomatic patients, the American guidelines say, to quote, might be reasonable. Look at that, might be. In highly selected patients, but its effectiveness compared to best medical therapy is not well studied. Now, with these kind of recommendation, you can interpret the way you want. Sky is the limit. Stenting guy is saying this supports stenting, endarterectomy guy is saying no, it doesn't. It's a castigation of stenting. So these are the languages which have been used. So writing a commentary in the June issue of General Vascular Surgery, Cambria from Boston says, to quote, no doubt we are once again in the midst of a great controversy, and this is a statement as recent as a journal which is just 24 hours old. Particularly asymptomatic patient, and the overall role of carotid artery stenting is again in the midst of a controversy. A word or two about combined procedures. Well, we all know both stenting and endarterectomy have a role, but significant morbidity attached to these procedures. And to make matters still worse is this recent publication by Mahmoodi, who looked at bypass in severe carotid stenosis with and without carotid intervention, found similar CVA, similar in a hospital, and 30-day mortality, absolutely no different. Therefore, if you look at the American guidelines, the latest, there is no class 1 indication for carotid intervention in a combined procedure. For symptomatic patient, it is a class 2 A indication. For an asymptomatic patient, it's a class 2B indication, not even class 2A. So what's the concluding message? Well, ladies and gentlemen, the two procedures are very much complementary. We should not be taken as antagonistic. It's just that we have to find the right indication for each one of them, which we may not be clear today. But a lot of advances in stenting, we talk of flow reversals and mesh covered and all those kind of, so things are evolving. We all know that there is a countervailing effect of higher strokes in carotid stenting and a higher myocardial infarction and endarterectomy, but overall the results are same. Probably in elderly patients, marginally endarterectomy is better. Maybe in asymptomatic and younger patient, both can be tried. But more important, we have to customize to our own needs. And we have to look at ourselves, whether the patient is symptomatic or asymptomatic. There is sufficient evidence going for, the two. We have to look for the age of the patient. What are the other comorbid conditions? More so for underdeveloped country like us, the cost factors are very important and we cannot ignore them today, and must also keep in mind that most of the data we were talking of yesterday, when medical therapy was absolutely different. Today, the medical therapy is a world of new developments have taken place. So if you look at these recent publications, the best medical treatment today is very adequate, and there is a space to study which is looking exactly at this, comparing endarterectomy with stenting with best medical treatment in asymptomatic patients. Until such time we have adequate data, we will have to customize therapy to each patient's personalized needs. Thank you.
You said that every treatment, every trial can be interpreted the way you want. Simple question. If you have this is what will you opt for yourself? If you are asymptomatic and if you find yourself asymptomatic, carotid artery stenosis significant, what will you opt for out of the three?
Personally, yes. I think there is, with the current medical treatment, I won't opt for any intervention.
You will go only for medical treatment?
Yeah.
Okay. But there is no data for that.
And the definition of asymptomatic, as you mentioned.
Obviously.
It's not just if I go thoroughly that it is asymptomatic. I will also look at plaque characteristics. If it is a smooth plaque with all the plaque characteristics, then, but if it is a nasty plaque, I mean, you know, if it is an irregular, high lipid core, where the chances are much higher, then I would probably go for some kind of a procedure. It's embarrassing, you know, to ask a surgeon what would you go for. And I don't think I'll be best because I can't give you my gut feeling on that. But I will look into multiple factors before. It's not a yes or no, 2 into 4 situation, no. It truly will have to be evaluated.
Mr. Chairman, we'll move on to the next presentation. Thank you, Dr. Yadav.
Thank you.
Just have a small question.
Okay,
Dr. Jadhav.
while Dr. Ajit comes over for his presentation. Yeah, can you stay on, sir?
Dr. Jadhav,
Yeah.
just asking you about the higher incidence of MI. Now, in all the trials, we know that in the CEA subgroup of patients, it was the elderly patients who have been subjected to CEA. Even in the CREST, patients who have been refused the cash, they have been transferred to the CEA criteria. And not only that, apart from the immediate MI, which has been higher in the CEA group, the long-term MI or the other complications, when we look at it in the CREST, it has come to be almost the same. So if we are actually operating on the higher age group patients, having an MI is always I think, a standard complication. And probably if we are subjecting the higher age group patients to both in the same category, the percentage of MI might come down to the same as to either.
Your point is well taken. This point has been thrashed out in literature repeatedly.
Yep. And the other thing is now
This is
with
not comparing apples to apples.
Yeah,
and
and-
your point is well
and
taken.
now with the CEA done on the local anesthetic and everything, the recovery rates from the previous operators is also much improved. So cost-wise is much effective as well.
Well, this local anesthesia business has been totally sorted out. It gives no added advantage.
No, not that, but obviously, if you totally, the total cost and everything for the patient's surgery and everything, it comes
Yeah,
down.
unfortunately, you know, we should have had more time for a throbbing issue like this. You know, this is not fair. But in case we find a little more time, why don't Dr. Yadav, you stay with us here and we'll shoot all the questions at him. We are in
Yeah,
pressure to
thank you very much, Mr. Chairman.